There we go. I was on
Here we
mute.
go. That's much better. Okay, perfect. Hey, Betty.
Happy Baby Friday. Welcome back to another session of Healthcare Happenings. I am Betty Hovey, and I am with my good friend and colleague, Sonal Patel of SP Collaborative. Hey, Sonal.
Hey, Betty. How are you today? Hi, everybody. Good.
And we have a lot of people coming in and saying hi already, so that's really good. We have Barb Shaw. Oh, Barb's here. Hey, Barb. And Sonia was our first one in today saying hey to us. So, hey, nice. Sonia. And we have Kieran and Marie. So we got a lot of people coming in. So good.
That's wonderful.
So
wonderful.
What we're here today to discuss is our third part in our 3-part series on our auditing and the audit process. And so prior to this session, our first one was on preparing for the audit. How to pick it, what kind of audit you're going to do, all of that good stuff. And then our last session for the audits was on actually doing the audit. So we did that one in our last broadcast. And then today we wanted to wrap it up with the audit reporting and what comes after with all of that stuff. So that's kind of where we're going. So for those of y'all who missed either of the first 2 sessions, you can go to my YouTube channel and you can watch the other ones there, plus all the past healthcare happenings that are up there. I looked at that the other day and they had some of the first ones that I did. And I was like, oh, Lord. It's just you learn so much as you start doing them, So it was very, very different when I first started doing them to how I've kind of morphed into it today. But that's good. That's how it goes, right?
That's how we grow. Exactly. We all have to start somewhere.
Yes. And speaking of that, Sonal, before we get started, I want to remind everybody, Sonal, I don't have your Sonal. If you want to find her on LinkedIn for her company, as I said, it's SP Collaborative. So here is her company LinkedIn page, and I will cut and paste those into the chat so people can go check it out there. And she also, for her personal, if you want to follow her personally and follow the company, you can find her here for her personal page on LinkedIn. And I, as I said last time, I think it's a good idea for those that are watching, if they want to, get different things, to go ahead and follow both pages. Because I know on my LinkedIn personal page, I post different things than my company CHCS posts. So if you want to kind of see everything that we're doing, just go to each one of them and, follow on both sets, because at least I do. Do you do the same thing, Sonal?
Yeah, I learned from folks like you, right, who've already had your own LLCs, your own companies established, right? So I've learned from you that I absolutely do post different things on the company page versus my own personal page. So yeah, you'll always get something fresh and different on each platform. So yeah. For sure.
And I tell people, y'all will know when it's from me versus the company page, because I try to be a little more professional when it comes out from the company, but when it's something that I'm posting, it always says, hey, y'all, and then, whatever it is that I have to discuss. So that's how you kind of know the difference.
So true.
Now, also, too, don't forget, Sonal can be found with her podcast, which is Paint the Medical Picture. You can get it on Spotify, on Apple Podcast, like anywhere you can download that kind of stuff. You can find her. So this is just the Spotify one that I put up here. But if you look under Paint the Medical Picture podcast, you will find, a way to get to her one way or the other.
Yeah. I love it.
And we also Sonal and I will both be in June 9th through the 11th in San Diego at the Business of Medicine Retreat by the Sea. Boy, that's a
mouthful. Yeah.
Medicine, retreat by the Sea. So is going to be put on by Advanced Coding Services. And both of us are really psyched about doing this. It is going to be at a university there, and we are all going to be just kind of communing together for the weekend. So we'll eat together, we'll hang out together. So if you are in one of the sessions and then have a question, then you didn't get a chance to ask, well, when we're eating, you can, sit with us, come over, ask us, continue the conversations. So it's not, stuffy, and you don't have to wear your business clothes, and you can wear a t-shirt and shorts and, flip-flops, whatever makes you comfortable to come into the sessions, all very relaxed. And so it'll be a nice, intimate setting and a good way to network with others and really get to know people, us as speakers, those of us that will be there. And we've got Beth has put together a really good lineup. Sonal is going to speak. I'm going to speak. Christine Hall is speaking. Brenda Edwards, Pam Vanderbilt. We have Ruby Woodward. So we have a lot of heavy hitters, so to speak, in our industry that are going to be there. So I'm really, really psyched about it. So make sure, let me see if that's still, no, it doesn't. Make sure that you go check it out at advancedcodingservices.com. I'm trying to get my thing to load. There we go. So these are some of the sessions on HIPAA. Both Sonal and I are going to be doing some E&M stuff. I'll let you, Sonal tell you about what she's going to do with it, but mine is going to be more of a hands-on coding sessions that we're going to do. I've developed a game for E&M, and so we're going to play my coding game. So that'll be kind of fun to kind of get us all prepped and make sure we're on the right track with our E&M. Sonal, your session, you've got 2 sessions, but your E&M session, you're going to hit what?
The new auditing standards of 2023 and beyond, right? Really interesting slant to take, because we've all been just, drowning in our 1995 and 1997 way of doing things, right? That approach is very, very different than what we should be doing today and beyond. So that's the approach. And I know your hands-on stuff, actually looking at a few samples, is going to be really helpful for all of us to take a look with a new lens. So it's good.
Yeah. I can't wait to play the game too. I love playing that game. So that'll be fun too.
It's going to be fun. Yeah.
And then we'll remind everybody before we sign off about it again too. But we've got 2 weeks. So if you are thinking about attending, make sure you go to Beth's website at advancedcodingservices.com and take a look at what's on there. I will cut and paste this into the chat also, so people can go take a look at it. And I don't know if Lady, I haven't seen a hey from Lady yet. She might be coming back from the AAPC conference though. So that may be why, because usually she is one of the first people in to start chatting with us, and I haven't seen her in there today. So, and I think many people that went to HealthCon are probably making their way back today. So they can catch it on the replays on YouTube, as I said before. So what we're going to talk about today, as we said at the beginning, is the reporting for our audits. So there's different ways and different kinds of reports you can put together. And we kind of talked a little bit about it last time about using audit software. So are you going to use audit software? What do you use it for? Those kinds of things. Oh, Brabiella said she's still enjoying Nashville. So yeah, she must have stayed over a little bit. So that's good.
Oh, that's great.
So
that's great.
As far as the software goes, for people that are listening in today, if you do use auditing software, please go ahead in the chat and type in and tell us what software y'all use.
Yeah.
And,
Nice.
if you like it or not, what do you like about it? So that others that are on the line, on the session, if they're thinking about getting some, they kind of have an idea maybe of what to look at. I think with some of the audit software, there's pros and cons, to using it. I think the pro is that obviously for using software, you probably can get into a little bit of a faster groove and have everything kind of look clean. But to me, a big con to that is a lot of times, just like with E&M notes, right? You have the template. So you end up seeing to where everything starts looking the same.
Exactly.
And so then you get this report and it just looks like it's the same thing said over and over and over and over. And who wants to read that?
Exactly.
You get, I think some people can put too many of those canned statements in there. And I remember I was using one once and every audit report would end up being like 50 pages long because
Right.
of all those canned statements, and it would
That's
give
right.
one for each provide. And so it would be one page sometimes would take it up with just one note because of those canned statements that would come out. And then it was the same ones over and over and over. So not only was it huge, it was also just repetitive. And I was like, who wants to read that? And so people were just reading the executive report. Yeah, nobody was reading all that detail. So you spend all that time in doing this and make it all nice and pretty, and then nobody looks at it because it's just too much. What do you think?
Yeah. I mean, we touched on this before, right? That you and I like to individualize our reports, which is why I myself personally haven't really utilized a audit software in the work that I've performed before, because you're right. When I've looked at previous consultants or companies, wherever these audit reports come from, they can be massive for exactly those reasons. They are simply templates that are copied and pasted again and again and again, right? You can exchange the product and the provider wouldn't even know. You know what I mean? Because it's literally the same thing that you've done for the other guy, So I think that's a big drawback to that type of reporting. We really want to make sure when we conclude the audit that we draft original, right, thoughts and recommendations, not only in our executive summaries, but throughout the report, right, specific to an individual date of service, for example, that really stands out with a finding, right? You really want to tweak your language individually for each and every provider, for each and every date of service, because you also really want to make this cost savings as well for the provider or the hospital system or whoever that you are auditing for, right? We really have to take into account the budget for the potential client as well and work together. So that can't really be addressed or relieved if we're simply using that software to, perpetuate the same data again and again and again and again. It has to be individualized. If we're trying to teach our providers to individualize those patient encounters,
Good point.
we
Yeah.
should be doing the same thing, right?
Yep. Yep.
So, yeah.
And it doesn't do any good. If they won't read it, they're not going to get any education. So, I mean, if it just looks like
No.
it's the same thing, they're just going to go,
Yes.
yeah, whatever. And
50 pages. They will not read 50 pages. We want them to read their 50 pages in a JAMA article in the weekend,
yeah,
as
yeah,
their relaxation time. We don't want them to be reading our reports of 50 pages. They're going to throw that out. It's not
yep,
effective, right?
yep.
Yeah.
But yeah, so as far as software goes, and now, this of course is not an all-inclusive list of some, but Sonal and I were doing a little research, and Healthicity is one that is put out by AAPC. There also is GEBS. GEBS Healthcare has an audit tool. Most of these two now are cloud or downloaded software that you would have living on your laptop. Some of them are cloud based, so they all have different kind of things to them that people like, don't like, that kind of thing. So I would say if you're in the market for auditing software, you just check out everything that you can. Some of them have free trials, some of them do not. Price ranges I've seen have been all over the place.
All over the place.
Yeah. We have some that are like you have to buy a year license. Some you can pay monthly. Some are like in the $80 a month range, and up to, like, we've seen some that have been a couple hundred a month range. So I mean, it just it's widely varied.
Yeah.
So look at your budget. Look at what the things offer. What you need it to do, and then if they have a trial, do the free trial.
Take it.
If they do demos, you might want to get a demo and kind of watch and see what it does. Ask a lot of questions, because just like with an EHR, in my opinion, once you decide on one and you get into it, if it's not working for you, it's going to be kind of hard to change over and to get a different software in. And then, it's just like changing EHR software. It's not fun. So really kind of take a look before you pull the trigger, I would say.
Agreed.
And
you've got to do your research.
Yes. MD Audit, IntelliCode. There's also Swift Audit that was designed by it's Barbara Moy. Shirley Moy. Shirley Moy. So Swift Audit is another one. And you want to check out, because some of them are exclusive to E&M, and some of them have E&M and also surgical that you can do in there too. So you want to take a look at that issue also. Now we have a somebody who's made a comment, and again, it's because it's the LinkedIn user. I have no idea who this is. Says,
and it's not me this time.
Usually
because I'm
talking.
I
think that's Sonal. So it says they developed their own audit software tool developed by their coders. So that's cool.
Oh, wow.
Fully customizable, transparent. They currently only grant access to their clients and for internal audits, but maybe there's a way to offer it to a broader market. So
Awesome.
True. So if you want to put in the chat, go ahead and enter in your contact information, so that if people want to kind of reach out to you and ask you questions about the audit software, but that's a nice offer there. So, and by the way, lady did chime in. So she said, hey, from Nashville. Here? So yes, so she is here.
Awesome. Hey, lady.
So, hey, lady. And Kimberly Joe Levette Williams is also here. So we're getting kind of the old gang running in here. So nobody's mentioned any software that they're using other than my LinkedIn user. So I don't know that anybody else has comments. So we will move into our other areas. If you do, just throw them in the chat, and other people can, take a look at them as they're listening to us too. So now, whether you use software or don't use software, I think there are specific things that you always want to get in your audit reports. And as I said, mentioned, the executive report, I always found that from of upper administrative part, when you have your detail where you're going through your comments about, you didn't have this piece, or you should have documented this better. An executive doesn't want to read all that stuff. They don't want to get in the weeds. They just want the down and dirty, how did they do? What do we need to work on? Is there an issue? So I always include an executive summary that will say, this many physicians and APPs were audited, this many records were audited. here's their percentage, of how they did. And depending on what you're looking at, is it just the CPT? Is it also including the ICD-10? So, you also have to get that kind of settled out with your client, or internally, if you're doing it, with your practice, at what exactly they want to keep figures on. Because I've been at some practices that really could care less about the ICD-10s. They just wanted to know that they were documenting properly for the CPT. So I'm okay, fine. And I've had others where, they want us to look at everything. So, you'll have to kind of decide on how you're figuring your percentages, but, you also give that out, and findings and recommendations. So those are the things that I usually include in an executive summary. What do you usually put in yours, Sonal?
Those are exactly the points that I touch on. And you especially want to address if you happen to be working for an attorney as well, right? We really need to be specific on the methodology that we're using,
Yep.
how we helped the practice choose these particular charts that we want to look at, these particular claims, these dates of service, the modifiers, if we're honing in on something specifically. We really want to try and include that as well in an executive summary also. But the most important things are, right, we have to be transparent and communicate with our client, right? What is their end goal, right? Why did they come to you? So make sure that that's also spotlighted in your executive portion. And again, even if you're using that audit software, which I'm sure they're all amazing, we need to make sure that we're individualizing it, right? So yes, it might populate some things that are templated, but you can also tweak it when you receive it, right? That's kind of my biggest takeaway when you're trying to save time, trying to be efficient. By using a template, you can definitely address the fact of individualizing it for each and every provider. So yeah, we really want to see that in the executive summaries for all of the audits that we're performing for all of our clients throughout the year, right? And so absolutely true. Your percentages will change based on what, columns of data we are addressing. If it's going to be those CPT codes and HCPCS codes, the modifiers or not, the diagnoses or not, right? And then all of those comments. And then what about our payers, right? That's also a big thing that I think I touched on at the last conversation.
Yep.
We really need to make sure we address the payer in the entire audit process, because many of our providers are not going to have just an audit on patients for the Medicare population, right? They're also seeing people who have Anthem or Cigna or Aetna. So we really have to be specific on looking at those reimbursement policies as well that will affect the audit process and all of our findings. So I think that's really important to include in the audit report. Yeah.
Yes. Yeah. The methodology is something that I wasn't thinking about, that is very, very important. I usually, at the beginning of my executive summaries, I put that, CHCS was employed by, or was engaged by, whatever the practice was, to perform audits, and
Right.
done using rat stats. And, so I do make sure you kind of step by step through,
Right.
to show that it was truly randomized, or if it's targeted for
Or
some
if it's
reason, like
targeted.
you're looking
Yeah.
at consults, when we used to be able to bill them to everybody, that was
Yeah.
a common thing that I would do audits on, because
Right.
everybody was worried about that, because nobody was doing it right, which is why we ended up not being able to do them anymore. But I did quite a few specific targeted audits on just consults. So, you would kind of state that at the beginning of what you're looking for. So I will do an executive summary. Usually it's a page, maybe two, depending on how much how many physicians and APPs are being audited, so
Right.
sometimes they can get a little long, but somewhere between 1 and 2 pages is really, I've never had one that's gone further than that personally. And then you get into the detail. Now, when I do the detailed ones, and as we were last time talking about, you and I both are old school, and I'm back to using my Excel spreadsheets, so I make the Excel spreadsheet for it, which contains the patient's medical record number. I don't use patient names on mine, just, for safety reasons, because you never know who could be looking at it, get their hands on that kind of thing. So I use medical record numbers, date of service, who the provider, what the physician or APP's name was, and then what the CPT codes were that they assigned, what the ICD-10 codes were that they assigned, if we're looking at ICD-10, and then what was audited. So what the recommended codes are, both in CPT and ICD-10, if we're doing both. And then I have also a column where I put comments. So if there's something specific, and the payor, another column for the payor, that if there's something specific in there, like they built this, they wanted to report a level 4, but with the MDM, the data elements only raised to low, and this element only, to where I can be a little bit more explanatory in the comment section, so that when the person that was audited was reading through their report, it wouldn't just be, it's wrong, or it's okay, fine. There has to be something, at least in my opinion, in there, especially if you're looking at payors for things like Medicare doesn't allow this. So that's why this, this one code, because it bundles under NCCI, so you can't do it, anything like that. I like to always put that extra information in there. And then when I move it over onto the reports, every provider that was audited will have their own section, and then go section by section, so that if they want to, the practice wants to give the individual their own audit results, they can do it without them being able to see everybody's and how everybody did, because people get a little funky about that. So Shelly and Kimberly both, just for the Excel spreadsheets, Kimberly, and then
I love it.
Shelly said, "Me too," but I'm old, so so yeah, it just I like the audit software for the reporting capabilities. That was something we were talking about, Sonal, just to kind of throw back on that for a second from the Excel spreadsheet issue. But the reporting that you can do from some of these softwares is very good, because you can do tracking, like how they've done on the past 3 audits you've done, so they can kind of house that information and put it out in ways that I think could be very helpful. So I like that part of the auditing software. More than I like the auditing software specific to each and every provider kind of thing. So
totally agreed.
Lady loves Excel too. So good. I was thinking we're dinosaurs on this.
So we're not alone. Okay, good. Thank you, everybody.
And then once you put that all together and you deliver it, with your clients, what kind of is your next step after you deliver the audit report with everything in there?
Okay, and I just wanted to step back. I also must include resources in the audit report, right? Like, it's fine to include perhaps a link or something in the comments column of your Excel spreadsheet, just so you remember that you need to, translate that again into your report, and make sure that you have that citation, and you really want to provide your physicians with every resource possible that you used in your report to help support your findings, your recommendations, etc. So that's a really key piece that you need to include as well. And of course, with the current state of the audits that my friend Betty and I are doing right now, A lot of those links are about evaluation and management for 21 and 23, right? So make sure you look in the weeds of all of the commercial payer policies, right? Because they all have their own policies on E&M coding for right now. So they all have links. They all have links to certain PDF files that they have for what they support in today's standards. So I normally give my providers, a week if they need to take the time to really read, digest, come up with questions for when I will then request a circle back time, right? Where I want to talk to them face to face, whether it's in person at the hospital, at their office, or if it's on Zoom. Um, you know, we really need to have a open, transparent conversation, communication about our findings. And it can literally be, line by line, patient by patient encounter. Whatever they need is, I believe, as the auditor, what we need to deliver, right? It's whatever they need. If they need to really understand the guidelines that were implemented in 21, right? That was still 2 years ago. But I know you and I are still seeing the education that really wasn't received, or they didn't take it up. They didn't have time to do it. They thought they could wing it. I really don't know. But I do know for a fact that we are still seeing a lot of issues in documentation standards that aren't being met yet. So,
Yeah.
I think it's
Yeah.
key that we take the time, whatever time they need, to, help them understand the education that we've provided. So, yeah.
Yeah, I think I still think that when we first took the leap to the 2021 new standards, that a lot of places I heard over and over and over again that, oh, it's not going to be a big deal.
It's
Oh,
not a
it's
big
going to be so
deal.
easy. It's going to be a
Oh,
lot
yeah,
easier
yeah.
now. We don't have to hardly put anything in there. And, once people started looking at the notes, and it's not as straightforward as people think, especially in the data column. I actually have heard from some consultants, I'm not naming names, that have said that when they train providers and educate providers, they tell them ignore the data column because you
Oh,
only need 2 of 3. Just don't even use it. Just
oh,
concentrate on the problems addressed and the risk. And I'm like,
mm,
that's one way to go, I guess. But if you're in a specialty that does a lot of data,
data.
you could be
Yeah,
doing a huge disservice by telling just ignore it
right.
because you don't understand it or because it's kind of convoluted. Well, yes, but you have to understand it because that's what's going to support the services you're doing.
Exactly.
Orthopedics, as we have, are involved in right now,
Yes.
there's a lot in that data element.
Mhm.
Cardiology, there's a lot in the
Mhm.
data element. There's certain
Mhm.
specialties that really now get better credit than they
Yeah.
used to under the old guidelines, because before it was, I don't care how many labs or how many x-rays or how many whatever, you get 1 point
You just
for
get
the
one.
70,000, one for the 80,000, and you were
Yeah.
done. And
Right.
so it was kind of like, man, this is kind of, back then I would say the data was more useless. But today, because it's each unique
Mhm.
source,
Mhm.
that for those specialties that are heavy in data, it really helps them.
Right.
So,
Exactly. Exactly.
but that needs some education, and
Yes.
that needs some, and there's still a lot of people in the old mindset. So
Mhm.
where they just put labs.
Yeah.
Okay. How
Yeah.
many? What were
Right.
they?
What were
So
they? Right. Right.
doing the audit brings all of those things out to where you can do
Mhm.
the important piece, which is education.
Right.
And I really think when you do audits, to me, the audit is like a means to an end. The audit isn't like the be all end all thing. I don't concentrate so much as on the audit as I concentrate on the education that I give off of the audit. I look at the audit as more of an educational pointer for me than I do
Absolutely.
as anything else. And that's why, when we do our audits, Sonal and I both, we, as she was saying, we have to round back, let them digest it first, of course, but then you want to make sure you round back with them and have those discussions, because if you don't, one, as we were saying, if they're getting this long thing, or even if it's more compact and individualized, if it's 15, 20 records and it doesn't look like it's going so hot for them,
Right.
I've had physicians where I've gone back and had the meeting with them, and they've admitted to me that they read the first couple, but because there were some errors in there, they didn't want to read anymore. So they just
That's
stopped looking
right.
at it,
That's right.
so you have to make sure, because then again, it's not doing them any service. You're not helping them, so go back. And with me, I also use it for, it could be used for group education, right? We could take the aggregate of everybody's things, look through the audit and see, are there common errors that everybody seems to be making, and build an education that could be given to everybody at once. Like, here are the main things and the main issues that we saw when we did this audit. So be mindful of documenting this and looking here, whatever the thing is, and not, calling anybody out, that never works well. And then you can also do the individualized. I always make sure, because I've had physicians and APPs tell me things when we've been doing our educational things off of the audits that they would never say in a group setting. And
Yeah.
always do that one-on-one time with them to where I can go through. And like you said, sometimes it's case by case by case. You are going through each and every note to point those things out to them. But that's for the physician and APP. That's where the gold is. It's not in that actual report. It's
Right.
in that discussion that you have with them, where you're giving them one-on-one education, right?
Exactly. That's exactly it. I just talked to a doctor last week on a report, and he came back with so many, questions on the findings. And that's the brilliant part, is that conversation that you get to have, right? And try and help them understand, okay, when you're talking, I understand what's going on with the patient, right? I understand what you're trying to diagnose. I understand what you're trying to do in the plan and the assessment and the med management. But if it's not documented, right, the documentation doesn't say any of that beautiful stuff that he just told me in our conversation, right? So I try to make them understand that all of that beautiful stuff that's up in their head has to be put out onto their documentation. And I think, because you and I have so much experience with actually talking to them one-on-one for such a long period of time, that's where we see the real benefits, right? Then they understand, their light bulb turns on, like, oh my God, you're right. I didn't write that down in the documentation. I said it just now very well about that patient in that encounter and what's going on, but it's not in black and white. It's not written down. So I think it is that, verbal communication of the education that has to happen. And it has to be that two-way dialogue, so we can help them understand, right, what the payer wants to see in documentation for them to receive that appropriate reimbursement. I think that's the biggest key. Yeah. So you were talking about the MDM stuff, and we shouldn't really advise them to drop one of the columns in their practice simply because they only need 2 out of 3 of the columns to meet MDM, right? For the new standards. I don't think that's good advice or a good recommendation for any practice, whether it's general, peds, internal med, derm, whoever. I don't think that's a good idea, because they need to understand that that entire table of risk, right, is pretty much similar to what they learned before in 95 and 97, right? It's just kind of reorganized, revamped, redefined. All of that type of education needs to continue happening. I don't think we're done yet. I don't even think we've begun for 2023 standards, right? For the inpatient space, et cetera. We just started. We have a long way to go. But as we said, our thread throughout today's conversation is we still see glaring issues in the outpatient and office space, right? Which we've already had since 21. So it's 2 years later and we still see issues. So I know we have a long way to go. And thankfully, we have some grace time, fingers crossed, some grace time for the payer audits that we know will be coming out for these new E&M standards, both the 21 and the 23. Hopefully a little bit more grace time, because those payer audits that we're still seeing today, you and I at least, are still seeing the old stuff, right? The old 1995, 1997 guidelines that are still under scrutiny with so many payers.
Yeah. I'm currently working with a client that has got she's got an insurance, a payor that's coming back after her, and the dates of service are as far back as 2017. So as I'm looking at those records, you have to use the 95 or 97 because, we didn't have the new ones at that point. So, when you're auditing, that's something else you got to make sure, you're keeping in the front of your mind at which set of standards am I using here, because you may have an audit depending on what's going on. Now that we're getting a couple of years into the new stuff, that you may have some that have the 2021 guidelines and some that have the 95 and 97 all in the same audit.
Yes. That's
so
a great point.
Because payors go, payors
Yeah.
go back. They don't just go like right now. They'll look 5 years back as they're looking at stuff, trying to, get as much as they can back from you. So it's important to keep up and keep your kind of skill up with the 95, 97 stuff, because we won't be done with that for a while. They're going to keep going back and looking at that older stuff as long as they can. And if they're looking at your 21, 23 stuff and you're not really doing great with that, you probably really weren't doing great under the 95 and 97 guidelines, right? It's something to watch out for. And on the surgical side, that's something too, when you're going over those. I find when I do surgical audits that it's much more involved on the one-on-one education with the physician, the surgeon, because at that point, it's really more tied to the documentation elements of, to making sure that everything is there to support that CPT code that's being done. It's not as subjective as kind of the E&M stuff is at that point. And there usually is a pattern that I find with surgeons that they kind of stick in. They can dictate their operative report without even looking at the patient's chart and have half of it done already because they say the same thing on every patient, so if you can find little things there that they haven't documented right, you can kind of do that correction. But I find when I do the surgical stuff, it's much more routed to the actual operative report itself and, highlighting out areas and saying, this portion wasn't documented correctly or in depth enough to support what you did, or the approach, excuse me, got to plug my laptop in, or the approach, wasn't stated in here to match up with what the thing was, that this is an endoscopic procedure, but, it looks like you did an open procedure or vice versa, kind of thing. So there's just different aspects depending on what kind of audit you're doing on what kinds of services. But I think the education directed one-on-one is where they get the most, the best stuff. And on the E&M side, I have heard just very interesting things when I ask physicians and APPs, like, how did you get to this code? I had one physician one time, and there was a newer physician, and they wanted me to audit her because they said, okay, well, she's been here, like 3 months now. We want to kind of see how she's doing. We want you to do just a little audit on it. So I did an audit, and it was bizarre. It was all over the place. I mean, sometimes she had things at 5s, like billing level 5s for that I looked, and I'm like, if I stretch it, it's a 2. And she had other times when she was reporting level 2s when they should have been 4s. I'm like, okay, she really is not getting this. Something, because sometimes it's not like the one coder, how we would get those. Everything's a 3 kind of.
Everything's a 3.
All over the place. And so when I sat down with her to do her education, I asked her, I said, what do you think goes in? How do you come up with your E&M levels? What's your thought process when you're doing it? I think that's an important question to ask when you sit down and do their education. Sure. Always ask them where their thought comes from, because you can't help them and you can't correct a bad thought, unless you know what they're thinking. You're just kind of stabbing in the dark. And so she said, well, when I first got here, they teamed me up with the seasoned doctor, and they told me that he was going to tell me how to do that E&M stuff. And I said, oh, okay. And she said, so when I started working with him, he told me, don't always use the same code. That's bad. And that was about all he explained to her.
Oh, wow.
So since she had that advice, what she would do was the first patient she saw was a level 1. If it's a new patient, it was a 99201. If it was established, it was 99211.
Oh my.
Was a 2. The next patient was a 3. So she went 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. And that's how she leveled her services out. She said, so I didn't always use the same one. He told me not to do that. So I would just round through the numbers, and I just keep going all day long. So I'm like, oh, now that makes sense. So we had some discussion on things, and, she greatly improved over her leveling and got to where it wasn't such a concern, but until you ask, until you do that education, you have no clue. And sometimes they have gotten little to no education. Sometimes they have gotten a lot and they ignore it. I mean, you just never know until you sit down and start talking with them. And that's where the resources, like you were saying, come in. Another just quick little, I had one physician that would argue with me about things. And so I would always, when I would send him things, I would send him 10 resources, about every, look in here and look in here. And I would put them all out, and I would send them to him with copies of like whatever the chapter out of the CMS manual. So he would get this stack back from me every time he would challenge me on something. And I wasn't being malicious. I wanted him to see that, no, here is why you can't do this. You have to get that out of your mind. And after I did that about 4 or 5 times, he called me once and said, well, I don't think that this is right. I think that I should be able to do whatever. And I said, well, here's why you can't do that way. And I gave him some resources, and I said, and if you'd like, I could, oh, no. That's okay. If you said it, I'll just do it. Okay. I that's okay. I won't do it anymore. So after that, because he trusted what I said, and he saw that I wasn't always just because I said so, or just, it was a flippant, oh yeah, sure. You can do that, or, kind of thing. So, but I find that really helps. When you're educating too, is heavily rely on those resources, but also understand where they're coming from. And that's what helps them the best. Do you have any certain tips that you can give that you use maybe when you're doing the education with the physicians that kind of help them accept and get what you're saying?
Well, I think my biggest philosophy that's always worked really well is always including in education all the things that they've done right in their documentation. Because normally there's so much good that our providers, APPs, everybody, our surgeons, everybody gets right, right? So I really want to probably start off conversations with all of the great stuff that I see, right? And then go in with some of those small dings that can receive some massaging, right, for improvement to be made, right? Because I'm not the payer, right? I'm always trying to find a way to showcase where they can make improvements, right? Because I think I can say this in almost 100% of the things that I've audited over all my years. The medical necessity is there. Everything is there. The patient was there. The patient was seen during that block of time, right? So all of those types of things, I know we didn't touch on that, but when you're going into the audit, you should always try and make sure, if you have access to their EMR or to their scheduling or something like that, to make sure that you have access to that laundry list of their patients that are coming in for that day, right? June 2nd, how many patients are being seen on that day? If there's 40, right, that's great. But then when you're auditing, you want to make sure that it's those 40, what were the time blocks, all of those things, right? So yeah, I think I can say pretty confidently that in my time, I've only seen evidence of the medical necessity in the documentation, right? It's just these little lingering pieces that require the improvement, right? And it requires the improvement, again, for the payer, so that reimbursement can be appropriately made. Because what Betty and I always strive to do is to protect the providers, right? We don't want to see the audits, because you will be audited at some point in your career. It's just going to happen. We want to protect you from having to pay back, right, so much grotesque monies because of these small errors that the payer identifies, but then they can balloon up into a huge amount, right, based on extrapolation and all of that nonsense that the payers have a right to do. So I think that's predominantly what our goal in education is with all of our reports, is to, prevent the greater mayhem that may arise from that inevitable audit that you will receive in your career from some payer or the other.
Yeah. And I find the going back to what you said about, doing that positive. My mama always used to tell me, if you want to get somebody to do something, or to, don't go in and tell them what they're doing wrong. You want to start out with, overall, it was pretty good. Now, over here, you could work on this just a little bit, and then go back to the positive again. But again, everything looked pretty good. And I always do that. I've always done that from taking this advice from her she always used to say that, girl. So I always go in there and always point out, what was good about it. And then and I call them tweaks. We just need to tweak a few things.
Exactly.
Because usually after going through med school and going through your residence, all that kind of stuff, they know documentation basics. It's not like you're going to see something where there's absolutely nothing in the documentation. I mean, I've seen some really poorly documented things, but I mean, there is documentation there. So I find that, if I kind of approach it that way, then they're not defensive, because once they feel like you're challenging them, then it can get into that, well, you're not a doctor. And I said that, and then that starts to come, and then you're going to get nowhere. Once they get defensive, you're done. They don't want to hear you. They're not going to hear you. I've gotten into some pretty heated discussions, and sometimes, depending on the situation you're walking into, it can be pretty stressful for both,
Oh, for sure.
for
For
them,
sure.
maybe they're getting audited from one of the payers or multiple payors. And so they're trying to take a look at this. And then now you're going to tell them, I'm sorry, but the payor was right. Your documentation doesn't support what you did. And you're trying to explain that to them. And all they're saying is that you're saying that I'm wrong and they've said I'm wrong. And now this is all, and then, the explosion happens. Which is why I always tell new auditors, just always try to remember that they're not mad at you. When you get into those situations, they're mad at what's happening or they're frustrated, but they're not mad at you personally. So try not to take those tense exchanges personally, and don't get defensive back, and don't get kind of snippy back. That's not going to get you anywhere. You have to kind of learn, to do that smoothly, and to say even, well, maybe we can come back to this at a later date, readdress it. I mean, I'm not saying sit there and take abuse from anybody, but, just try to recognize what's going on, and that, they're not really mad at you. It's not a personal issue. So try not to take that kind of stuff personally. And when I was first in consulting, I remember it was kind of difficult for me. Sometimes I would be like, I'd go back to my office and be like, oh, he was so mean to me. And those things, they're going to happen, but then you get used to, it's kind of like you understand better. And so just don't take it personally. And I wanted to hear a couple. Angela. Hey, Angela. She says, we are already dealing with UPIC audits for 2021 claims for their clients.
Yep. Oh, wow.
So what we are seeing isn't promising or reassuring that they know
the
new guidelines.
It's the UPIC. It's the UPIC. So that's not a good thing. The UPIC is not someone you want to see come into your practice. Oh, no. Sorry, Angela. Thanks for sharing that. Yikes.
Yes, definitely. So that they're starting. It's now, because it's usually after about a year, and it's been 2 years now. So so then next year they're going to start into where they're going to be starting to take a peek at everything else that got changed this year too. And there's some changes for next year that we were just on the AMA call on E&M. And they just had an hour-long session at noon my time today, where they were going over some of the E&M stuff, and also talking about some of the changes that we're going to see next year for E&M. They're just tweaks, nothing like huge like we've had, but a couple things where they're trying to make everything kind of match up and things like that, and try to give us some more information. Kind of watch for as they put out more information as we get further into the year, that there'll be some minor changes in the E&M section next year. Do we have, I just want to put this out there, and I hope I would not even want to try. I would badly butcher your name, sir, but we have somebody from Nigeria on, so I just wanted to kind of pull that up. I thought that was interesting. So thank you for joining us.
Thank
you. And one other thing too, because we're getting at the top again, Sonal, we're at the top of our hour already.
I don't even think we're done talking yet. Oh my God, we just got like warmed up.
But I wanted to put this up for y'all. Cigna, for everybody, it was all up in arms about the modifier 25 thing with all that faxing nonsense. It was supposed to start today, and yesterday they let out that, they're not going to do it right now. Now, they didn't say that they totally, realized that it was silly. They're saying that it is on hold indefinitely or something like that they're going to keep evaluating it.
They're going to keep evaluating it. Yep.
But they're not doing it. That's the big thing. So I will put this in the chat in case anybody wants to go and actually print out or look at the actual thing. What it is, it's just the modifier 25 policy that they had made, saying they were going to make us do all that. but at the top of it in red, they have a thing that says we've decided to halt it for now. So no faxing, none of that silliness on Modifier 25 from Cigna now. So they finally decided to pull back. They waited till the 11th hour, but at least they decided not to do it, which I'm so super glad about. That would not have been fun for anybody, and even them. For them, it would have been a nightmare.
The huge burden for providers and for Cigna. It was a ridiculous idea, which they came up with, and it was supposed to take effect last August.
Yes.
But it didn't take effect then either. So they're just going to keep doing this every year. They're just going to keep trying to implement this new policy, to submit your records with a minor procedure with your Modifier 25. And then they'll realize that it's a huge burden. And this, again, because they come out with this policy, our doctors, physician groups, the medical societies will have to, again, band together, write another letter. So again, all of that is still more work. So this is all, in my opinion, what Cigna is doing. It's just creating more work for these people to keep fighting back, which is great, but it's going to keep continuing. This pushback.
And I think with some that might be, they're just kind of testing. They'll throw it out there and see how much resistance they get until they hit a point where they think the resistance isn't as great, then it'll push through. So every time, anytime you see these kind of things come up, make sure you push back, take the time, call your society, see what they're doing, send notifications back to them, send letters for if you have physician groups or you're in a healthcare system, have a letter written or put together, because, if they don't hear anything, they're going to go ahead and go right through with it. So it's only when we show that, no, we're going to push back on these things, that they're like, oh, okay, we'll back off. So that's kind of where my mind goes with that, is that they're just kind of throwing it out there, testing that water to see how much resistance they're going to get. So keep up the good fight with that stuff when you see it, y'all.
That's right.
Any final words before we close for today? Actually, now we're a couple minutes over. So, but do you have any final piece of advice?
Well, we just have to continue providing education after our audits. I think year after year, we have to get together with our clients and develop some sort of a schedule for auditing this, that, or the other for their practice, and then come on back with our report and then continued education. I don't think this is a field that's going to end. I think it's only going to grow as healthcare continues to change and develop in the next few years as well, right? Especially with all of the new things and the new innovations and all of that that's happening in healthcare. That's not going to stop. So I think all of the work that we do is going to continue on and on.
Yep. Job security for us. That's what you got to think, right, y'all?
Yes, I think so.
All right. And I just want to, before I do the close to it, someone, again, it's a LinkedIn user. So somebody had put a question in there about us doing a defined audit process. So we will answer you offline on that. Thank you for the question out there on that. I just didn't want you to think, whoever you are, I didn't want you to think that we kind of ignored that it was out there. So thanks, y'all, for watching. And please go check out Advanced Coding Services so you can take a look at that retreat that Sonal and I will be present at in 2 weeks. So for those of y'all that are going, because we were getting updates on people that are signing up, we will see y'all in San Francisco or San Diego. And my broadcast then falls on the day that I get into San Diego on June 8th. So we're trying to put some different things together, Sonal and I, and some of the other speakers, where maybe we can do a little broadcast with a lot of the speakers that are going to be in there live, just do some kind of like Q&A thing or something. So just kind of watch for that.
Yeah.
But we'll have something up for when we get out to San Diego. But go check out Beth Schleiper at advancedcodingservices.com and check out the retreat, and hope that y'all can make it to go see us. It's going to be a lot of fun. But until next time, thanks for joining us for our healthcare happenings, where you come in to find out what's happening in healthcare. And we will see y'all next time. Bye.
Bye.